That was Thought for the Day with Chief Rabbi Mervis. The time now 11 minutes to 8.
How, if at all, should we ration hip operations? The question goes to the heart of the NHS. Ever-growing demand and ever-growing ability to make lives better, but limits on cash. The hip operation plan for some areas of the country seems to be don't do them unless the patient is in real pain, unable to function and to sleep because the pain is so bad. 3 clinical commissioning groups in the West Midlands have drawn up plans along those lines, and others may already be doing this unofficially. Julie Wood is Chief Executive of NHS Clinical Commissioners. That's the group that represents all the clinical commissioners. And on the line a few moments ago, I asked her how much pain someone should be in before they get a hip operation.
Clinical commissioners are really committed to ensuring that patients get the best possible health care, which will give them the best possible outcomes. Clearly, the NHS doesn't have unlimited resources, and it has to ensure that patients get the best possible care against a backdrop of spiralling demand and increasing financial pressures that we all see. So when we're looking at things like operations on the hip, knees or other joints, actually looking at the clinical threshold, asking someone to lose weight before surgery, is about trying to help them get the best possible outcome.
But that's different, isn't it? No, losing weight is one thing. Everyone can understand that because it has a better clinical outcome. But actually, how much pain should you have to be in before you have the operation?
Well, the Oxford Hip and Knee Score is a clinical guideline that helps a clinician and a patient assess when a patient is ready clinically for surgery. And obviously pain is one element that is looked at, but so is optimising the patient's chance of a successful operation.
But on pain, how much pain should there have to be for a doctor to be able to say, yes, this person must certainly have the operation?
Well, clinical commission groups are led by GPs. So the GPs who are looking at these sorts of decisions are taking into account all of the different priorities that they have to cope with, and are assessing what is the right thing to do for their patients and their population. It will vary in different parts of the country.
Really?
CCGs at the same time as they have to live within their financial resources. They have to look at access to A&E, to emergency care, all of those other things, and they're balancing competing priorities.
So you're saying, but just to make this plain, sorry to interrupt, but in some parts of the country then you're saying we're going to have to live with a situation where in some parts of the country you would have to be in considerable pain to be given a hip replacement or operation. In other parts of the country you wouldn't.
On a daily basis, commissioners are going to be forced to be making difficult decisions that balance the needs of the individual against those of the wider population. They will look at the level of surgery in this sort of situation that is currently undertaken and compare that to their colleagues and see whether they are in line with them or similar CCGs or not. And they will be looking at how they optimise what they do to get the best possible outcome for their patients.
Well, that was Julie Wood, Chief Executive of NHS Clinical Commissioners. Steve Cannon is here, who's an orthopaedic surgeon and Vice President of the Royal College of Surgeons. Morning to you.
Good morning.
What do you make of what you just heard?
Well, there are a number of factors that she brought up. I think the first thing to say is that your interviewer pointed out that what's going to happen is there's going to be postcode lottery in the situation.
It's quite interesting she accepted that was the case.
She accepted that, and we've been saying that for a long time, and it is absolutely iniquitous that you have this sort of system.
Except that, in some clinical commissioning areas, there is a reasonable amount of money, and in others, they're very tight for cash, and it's just a reflection of reality, is what she'd say.
It is a reflection of reality and the pressures the CCGs are in, but the methodology they are particularly using, the Oxford Hip and Knee Score, is not really a population-based methodology. It's actually a score that is used to an individual. So it's the individual being monitored through knee surgery or hip surgery to sort of judge where the patient starts and where the patient ends up 1-2 years later.
And you're saying this already happens, that some patients will have a certain amount of pain which will qualify them for an operation in some parts of the country and it won't in others.
Exactly.
And to what extent do you think it is reasonable to ask us just to live with that situation because of the shortage of money in the NHS?
Well, I think there is great problems within the NHS, and you and I will not solve those problems today. But obviously, what is good for a patient, what is best possible practice, which the Commissioner was talking about, is really what the patient ideally needs. that can only be judged by the surgeon who is attempting to do the operation. It can't be judged by a bureaucracy adding numbers on an Oxford hip score.
But if we said everyone should have a hip operation in the NHS in England who a surgeon says is qualified to have it and would benefit from having it, what extra resources do you think we would be talking about?
I think you would be talking about a significant extra resource. I wouldn't like to give I wouldn't like to give you a figure, and therefore the answer is we must really look at the funding of the NHS.
It just simply comes down to funding, doesn't it? I mean, we can talk about what should or should not be the qualification to get the hip operation, but actually what you're saying is if we want everyone to have hip operations, we've got to fund it somehow.
Exactly.
And to what extent in your profession and more widely in the NHS is that understood, or to what extent is there anger at the clinical commissioners for trying to find ways around it?
I think there's not anger, there's frustration, I think, in the surgical fraternity that they have to accept these sort of limitations thrust upon them rather than able to judge by their own clinical practice for which they're well trained to do.
Is there anything reasonably that the clinical commissioners could do to kick against it? Because you've got, I mean, the story today, of course, is these three CCGs, Reddish and Bromsgrove, South Worcestershire, Wyre Forest. They appear to be sort of signing up to this now, freshly, newly, having taken the decision this is a way that this is something they need to do in order to save money. Would you say directly to them, don't do it, or do you accept that actually they've not really got much choice?
I think what I would say to them is they've got to think very carefully whether their assumption is actually going to work, because the patient is actually going to stay under clinical care. He's going to need painkillers, he's going to need physiotherapy, he's going to need monitoring, which is another expense. So I think it's probably futile to say that it will actually work.
You bring up the patient, and I perhaps should have brought up the patient earlier on, because this can make a huge difference to a person's life, can't it? I mean, a really huge difference.
You and I know that hip and knee replacement is one of the most successful operations at improving the quality of life of the patient. To restrict that in English practice, or UK practice, seems nonsense.
Steve Cannon, Vice President of the Royal College of Surgeons. Thanks.
3 minutes to 8, Jay Wynn has the weather for us. Jay.
Thanks, Nick. Good morning, and it's a cold and frosty start for central and eastern parts of the UK. It's -3, -4 quite widely, a little bit lower.